Well, good afternoon, everybody. Welcome back to the first concurrent session of the day. The title for this afternoon's program is Asthma and Allergy, and we have three speakers this afternoon. The first speaker is Dr. Janet Davies. Janet is a Senior Research Fellow with the School of Medicine at the University of Queensland. His work is focused on applied allergy research and improving diagnosis, treatment and understanding of the immunological mechanism underlying allergic respiratory diseases. She's the author of 44 peer-reviewed papers and is the inventor on three patent applications, as well as being granted an Australian patent. She serves on committees of the World Allergy Organisation, the European Academy of Allergy and Clinical Immunology, and the Australian Society of Clinical Immunology and Allergy. She is the principal investigator of an international Australian aerobiology working group aiming to establish the inaugural national pollen monitoring network to assist with the management of patients with severe hay fever and allergic asthma. Please welcome Dr. Janet Davies.
Thank you, Peter. So it's good to have the opportunity to talk about this initiative here today. We got some funding this year from the Allergy Immunology Foundation of Australasia to inaugurate the Australian Pollen Allergen Partnership. Do you want to tell me the controls? The green should be forward. Yep, okay, green is forward if you point at the machine. Okay, so we know that there are a number of factors that are causative for asthma, and that a complex genetic predisposition is influenced by multiple environmental exposures to cause this underlying underlying inflammation. So two of the environmental influences are respiratory viral infections and allergen exposure, of which house dust mite and cats are very important, especially in children. But in addition, I want to focus on the influence of grass pollen allergy in triggering exacerbations of allergic inflammation and asthma. So for most people, when we think about pollen allergy, we think of hay fever or allergic rhinitis. But there's an integration between the allergic airway inflammation that happens in the nose in allergic rhinitis and that allergic airway inflammation, if it moves further into the airways, that might be contributing to asthma exacerbations as well. So we've heard already this morning about the global burden of allergic respiratory diseases of asthma and rhinitis. So globally, there are about 3 million patients suffering from asthma and 2.3 million with current asthma in Australia. For allergic rhinitis, that tends to be higher, with 500 million people affected globally and 3 million patients in Australia. And the connection between rhinitis and asthma is important because there's a threefold higher risk if you are an allergy patient with allergic rhinitis for development of asthma. And conversely, around 80% of people with asthma have what we call the allergic asthma. In a recent study that we've nearly completed, a multi-centre clinical survey on allergic sensitisation to different kinds of grasses here in Australia, the patients that were recruited primarily for a presentation of allergic rhinitis actually have a frequency of 39% doctor-diagnosed asthma. So this is a lot higher than that 10% frequency that you see in the general population. It's also alarming that whilst we understand the incidences of asthma and rhinitis have plateaued recently, the burden of allergic rhinitis has increased with doubling of pharmacy sales for antihistamines and nasal corticosteroids in the last 10 years to 2010. And another way in which there's a more direct effect of pollen upon asthma is the episodes of thunderstorm asthma. So on the 24th of November in 2010, there was a severe thunderstorm in Melbourne where there were 90 cases of asthma acutely presenting to emergency departments across Victoria. and some people in the room might have been involved in assisting some of those patients. But I understand it caused a severe problem with delivery of services to those patients. And these epidemics that wasn't unique, they've occurred. And if you have a look at I don't know if I have a pointer here. If you have a look in the Melbourne, there was an episode in 1989 and again in 1990. In the northern rivers of New South Wales, there was episodes around 2000 and 2001. And again, 2010, 2011, there were repeated episodes of epidemics of pollen-induced asthma presentations. So these are associated with extreme grass pollen daily counts, over 100 grains of grass pollen per cubic metre of air. And you'll notice that they occur in around a 10-year period, and they usually occur not just 1 year, but 2 or so years in a row. And this is coinciding with global weather patterns of La Nina weather. And we're concerned about this because there is likely to be an increase in these kinds of episodes with global warming and the effects of climate change. And these incidents haven't just been described in Australia, but also internationally. So if you look at Australia, you'll know that we have a very diverse and large continent. And we have a number of different climate classifications within our biogeography. Consequently, we have different kinds of allergen sources that predominate in these different climatic regions. And we have different kinds of grasses that grow in Australia in different parts. So we know most about the temperate grasses that are exemplified by ryegrass, or in Europe and North America, timothy grass. And a lot of our tools for diagnosis and treatment are actually based on these temperate grasses, and they were developed in Europe. However, for a large part of Australia, and I'll show you shortly, we also have these subtropical types of grasses that belong to 2 separate botanical families, the Bermuda grass belonging to the Chloridoideae and the Bahia and Johnson grass belonging to the Panicoideae. And my research that I'm not going to go into here shows that patients have species-specific IgE recognition as well as unique T-cell epitope recognition of the major allergen components of these subtropical grasses compared with temperate grasses. We also have different exposures in different regions of Australia. Unfortunately, we're not served well with good controlled studies of pollen aerobiology in major urban centres. But there have been some studies, predominantly in Sydney and Melbourne, that would indicate that we have a spring peak in grass pollen season, and that around between 18 and 20% of the total pollen exposure in a year is attributed to grass pollen. However, you can see that there's quite a lot of yearly variability in the level of pollen in these graphs. And the red zones are shading the areas where it's believed to be associated with symptoms of asthma, so greater than 30 grains per cubic metre. And so you can see there are a large number of days in the pollen season in Sydney and in Melbourne in which there is a risk of patients experiencing symptoms. And this would be similar to the European temperate grass pollen season early in spring. However, if you look at Brisbane, there was a study in the 1990s that looked at the pollen aerobiology. So the first thing you can notice here is that there's a lot of yearly variability, where some years the pollen load is extremely high and other years it's quite low. Also, I'm not sure if you can read the axis, but there's a shift in those months, so that the peak pollen exposure to grasses in Brisbane occurs between December and March, and even through to April in some years. So it's not so much of a spring peak in grass pollen exposure, but actually a summer peak. And the other thing that these 2 studies were able to show us is that there's up to 60 to 71% total pollen in the air is grass. So the exposure level of patients in different regions is likely to be very different. So that was pretty much the sum of our understanding about exposure of patients with hay fever and asthma to pollen allergen triggers. So we realised there was significant gaps in our knowledge, and I put together the first Australian aerobiology working group that was supported by actually an ecology centre, the Australian Centre for Ecological Analysis and Synthesis. And they supported us to run 2 week-long workshops, and I invited these participants from different disciplines of science and as well as medicine, public health, allergy, immunology, to join me at Stradbroke Island for a week. And we all went there, and I don't think people quite had an appreciation for how much work was going to happen in this working group. But we actually missed the dinner at the pub one night because we were so dedicated to getting the work done, we missed the chefs going home. Anyway, we were able to pull together data sets from 17 sites around Australia and New Zealand and get a better picture of the diversity and the risk of pollen exposure in Australia. So we wanted to integrate diverse factors, both anthropogenic, so pollen and urbanisation, as well as natural, so weather and climate, and the biodiversity on the generation of the plants and the different types of plants in different regions, and therefore the different types of pollen in the air, the dispersal of that pollen, and then the impact of that pollen on patients. And as I've already indicated in the earlier slide when I showed you the people who were behind this, it requires drawing expertise from a number of different research disciplines. And this can be quite a complex thing to pull off because we all speak different lingo. So in the room you would have people, it really required us to get rid of the jargon and to speak plainly about what it is that is influencing pollen exposure and how that affects people. And that was the primary motivation for doing this research. And this is a picture where you have satellite remote sensing of the land cover across Australia. And we were able to integrate the different vegetation types and work out within a radius around where we had available data from pollen traps, what was the prevailing land cover. And you can just have a look from the north to south gradient there and see that there are different predominance of the pinks versus the green colours. And that's just a very easy graphical way to integrate that difference in biodiversity that's present in Australia. We also then worked out what were the 5 top types of pollen that are observed in the air in 17 sites. And then we grouped those and analysed their similarity in the composition with their latitudinal gradients. And you can see that the brown colours and the blue tend to occur in the southern temperate colder climates, whereas grass pollen tended to be a larger proportion in the northern Darwin and Brisbane sites. And New Zealand, the sites were coastally located in urban centres on the grasslands near the plains, and they also had very high proportions of grass in their air. And we were able to look at the top 20 taxa and work out which months of the year were the 80% of the pollen occurring. And these little pie charts give a little bit of an indication. But in no way should we take away from this that this is when pollen is in the air of all of these different kinds of plants in these locations, because if you recall those initial graphs, you can see that there was differences in the amount of pollen produced in different places and year-to-year variability in pollen. So we're quite cautious about even generating a static pollen calendar at this point. And this is the distribution of the subtropical species of grasses that were collected from the National Herbarium, and temperate grasses in blue. And so, whilst I said at the beginning, most of our information around pollen allergy comes from the temperate species, ryegrass in Australia, you can see that there are Melbourne and parts of the southern island of New Zealand and Tasmania are pretty much the only parts of Australia where there's only the temperate grasses. For the most part of Australia, there's a coexistence of temperate and subtropical species of grass and a dominance of the subtropicals in the northern parts of Australia. And looking at the integration then of the pollen seasons, if you look at the middle panel on which is that? It's on my right side, so it's going to be your left side, you'll see Melbourne. So that's what we understood and what we thought about the pollen season, that it's a spring peak, it's pretty tight and reproducible between years. But if you have a look at Brisbane beside that, you can see these multiple peaks occurring. And you can see that it's not spring that we have the dominant grass pollen peaks, but in fact it's summer in March through to April. And that was also present, surprisingly, when we looked at the data in Sydney. Again, emphasising that we really do have quite a diverse representation of types of grasses flowering in different regions of Australia. And we shouldn't just think of it as just being a spring problem in Australia. The other thing I want to point out in this is the yearly variability as well as the variability between sites. And you can see that we have a biogeographical gradient in the season length. So you have a longer season closer to the equator and the season peak date. So the season peak date is often delayed as you go further south from Canberra to Melbourne to Hobart, for instance. And you tend to have more peaks or multiple peaks, which we suspect are the flowering of different types of subtropical grasses occurring as you go further north. And in terms of levels, we wanted to really understand if you take the prescribed thresholds of symptoms possibly occurring above 20 grains, between 20 and 50 grains, and a high being between 50 and 99 grains, and extreme over 100, then how many days in these particular regions when the pollen was counted for those short studies would have days that were in a moderate to high level? And so we see in Melbourne there are quite a number of days in those short spring seasons where there is extreme and high grass pollen exposure. But it was surprising to some that there were still days where there was low to moderate exposure levels in Darwin and Brisbane. And people had previously thought that hay fever and pollen exposure wasn't a big problem in Darwin and Brisbane, but in fact it's more that the season may not be acute and sharp as it is in Melbourne, but it's protracted and longer as you go further north. So it's possible as well that the types of symptoms may differ as well. So in Melbourne we suspect, and we don't have evidence of this yet, that the season is much more likely to cause patients to have very acute sneezing and runny rhinorrhea, whereas in a prolonged allergen exposure, the inflammation would be chronic and the mucus is thicker and more congested, causing more of the sinusitis type problems. So the clinicians have anecdotally described this to me, but we haven't been able to systematically evaluate that. So we can appreciate from our Australian aerobiology studies that we do have a number of needs in terms of understanding environmental exposure to allergens here in Australia. So the ACS Aerobiology Working Group revealed striking spatial and temporal variability in the grass pollen seasons, and variability in allergen exposure is important and has implications for how we then inform patients and manage patients. And that these static pollen calendars that have been produced in the 1970s are probably not useful in terms of formulating guidelines on exposure. So there's a need for a national pollen monitoring network to advance the clinical and public health management of millions of Australians with asthma and allergic rhinitis. And we need particularly to have a standardised network where the same collection methodologies and the same count methodologies are implemented in all sites. And so to do this, the Aerobiology Working Group is developing into this Australian Pollen Allergen Partnership. And the primary objectives are to build a national standardised pollen count network in 8 state and territory capital cities, to measure, report and forecast allergenic pollen counts across these 8 sites, and then to correlate the pollen levels with measures of allergic respiratory disease. And then, really to integrate that, we need to work out ways to assess if this intervention of providing pollen count information is useful. How do we evaluate that it has been useful? So we're still working on the best way to really judge the effectiveness of this knowledge provision. The secondary aims are to move this from the 1950s, where we're still using the same technology and it's heavily reliant on people sitting for hours at a microscope counting the pollen. We want to apply new innovative approaches to measure the subtropical versus temperate allergens, and we want to integrate this with the remote sensing phenology and weather data so that we've got really good pollen forecasting, not just for those 8 urban centres where we're going to count the pollen, but for rural sites as well. And it would be good to automate this process in future. So the sites are going to exist in our capital cities, and the program is going to look like this. We will have the pollen counts. There's a picture in the middle. Number 1 is the green pollen trap, the Burkhardt pollen trap. And number 2 is the total particulate sampler, which will enable us to measure the allergens within the pollen and to work out what species has produced that, because it's not always easy to see what type of pollen you're looking at under the microscope. In fact, you can't see the difference between the grasses. And the phenology data from remote sensing to look at the pollen source and the distribution of the grasses. So this is going to be integrated with weather data in partnership with the Bureau of Meteorology to develop a good evidence-based pollen forecasting model. That data will then be transmitted to the patient population and integrated with health outcomes to really provide an impact on management and education of patients. So we'll set up throughout the year pollen monitoring stations that will collect the grass pollen primarily. That's what we'll focus on counting. But the samples will be collected and can be integrated into an automated pollen count program so that we can gather data on all types of pollen, like trees as well and ragweed as well. And I will be involved in looking at the bioaerosol content for the types of allergens and the species from which they were derived. And we will also integrate that with phenocams to confirm the remote sensing studies of the pollen production. So this is just a slide showing you that we're able to amplify pollen DNA from traces from aerobiological samples, and that if you determine the sequence of a particular region that we're calling a barcode for plants, we're able to work out what species produce the pollen in the air. So this is a powerful new tool that a number of people from the European network are interested in applying in their networks as well. So we're going to not just be setting up the network, but we're hopefully going to be developing new innovative ways and leading the global initiative to improve pollen monitoring work. And the other thing is to deliver that. So this is Ed Lampugnani, and he's a postdoc at Melbourne University working with Ed Newbegin. And he's written a pollen app based on a study from one of our people, Danielle Medic, where she had a look at the correlation between patients' reported symptoms and exposure to pollen in the air. So the patients basically have the opportunity to tell us how they're feeling on a given day on a 5-point scale. This is a very simple questionnaire, so that encourages people to actually use it because of its simplicity. We then get that data and provide them with information. It's connected with local web pages so that the patients can go and find the information that they want. So this was launched in 2013. Sorry, I'm going on a bit long. In Melbourne, and in October 2014 in Canberra. So in Melbourne we've had 13,000 users and responses and 7,000 from Canberra. And you can see that there's a very good correlation at both sites between pollen in the air and reported symptoms. And graphically we're able to get information on the location of where the patients are, and so we can look at geospatial differences in symptoms. So Canberra, as I said, launched in October last year, and the little peak in asthma admissions was observed at the start of that rise in the high grass pollen levels. So our platform for integrating this will be to have a central AustralianPollen.com site, which will have a web of the individual city sites linking data in together. We will access some computer infrastructure to integrate the data, and we will be drawing on information from the Bureau of Meteorology. But importantly is the output. So we'll be connecting that in through the Australian Society of Clinical Immunology webpage and Asthma Australia, so that we can provide this information directly to the patient, to the general practitioners, and to the allergy and asthma respiratory specialists who are caring for the patients. Thus far, we have partner organisations committed to supporting a bid for, from the NHMRC as a partnership grant later this year from the Australian Society of Clinical Immunology and Allergy, Asthma Australia, the Bureau of Meteorology, and a couple of pharmaceutical companies, Allergen and Meter. We would like to also integrate more closely with providers of respiratory health outcome data, and we want to disseminate and translate that information into practice with predictive pollen forecasts, multimedia interaction, and providing information papers for ASCIA and Asthma Australia, as well as pharmacy education. And we hope that this will benefit the patients by providing improved clinical management for severe cases and region-specific calendars on the pollen season, and better self-management for those people who have mild disease. We hope to also establish a pollen alert so that those epidemics of asthma that occur in the pollen season could be managed better. And we hope to use this as a platform, basically, to empower patients, to keep the dialogue going, and to educate patients on avoidance of triggers for asthma, of which pollen is just one. And so our vision is here, and in the interest of time, I will just skip straight to the people and the partners who have so far supported this initiative.
Very much, Janet. We've got time for one or two questions, so there is a microphone at the back. So if you raise your hand, then Annika will bring the microphone to you. One over here.
Yes, Charles.
I enjoyed it very much. You mentioned bioaerosols, but you didn't mention fungal spores. Since they may be important, can I just
Definitely.
comment on where they fit into your overall plan?
We talked long about whether to include the fungal spores as well. So that data will be captured, and we will be able to count all the pollen spores that are there through the Classifinder automated pollen count. But really, in the initial setup, we want to focus on the grass pollens in the first instance, but we'll certainly be looking at the impact of the pollen and the spore exposure on health outcomes. Good question.
One more question over here.
Yeah, Mika Mäkelä from Helsinki. Thank you, Janet. That was wonderful, and I think this is exactly where aerobiology and allergen pollen counting should go. You are really leading the way globally even. I think you are doing fantastic work.
Thank you, Mika.
Your sensors, what you are in the automated system, what are they sensing actually, and how far are we in the real life setting from using those?
Okay, there are 3 different types of automated pollen counters available on the market, and they work in different ways. We want to initially start with the slides we will have already collected and putting them through a slide reader and integrating that data digitally with a neural network that can identify the pollen. The other way we're interested in looking at is like a flow cytometer that it's a Swiss invention, and they have basically developed a spectral analysis where they can look at reflection of 45 different colour spectra. So it allows them to identify the particle. So the Swiss group have offered to send one of their instruments down to us to trial and see whether it can work under our environmental conditions. We probably still are a long way off getting a reliance on that, but I think the work with the remote sensing is actually going to be quite powerful. The correlation is very strong. I didn't talk about that today, but it's looking very positive.
Okay, thank you very much, Janet. Please thank you for a presentation.